Thomas K.L from Department of Medicine, the University of Hong Kong. Today, I'm going to share our latest randomized controlled trial on AI-assisted colonoscopy. The title of our study is Computer-Assisted Detection versus Conventional Colonoscopy for Proximal Colonic Lesion, a multicenter randomized tandem colonoscopy study. Computer-assisted detection is a promising technological advance that enhances adenoma detection during colonoscopy. It has been confirmed by multi-randomized controlled trial. However, the role of computer-aided colonoscopy in reducing missed colonic lesion is still uncertain. The aim of this study is to determine the miss and detection rates of proximal colonic lesion by the computer-assisted colonoscopy versus conventional colonoscopy. Our study includes all consecutive adult patients aged 40 or above who undergo outpatient colonoscopy. However, we exclude those who could not give the consent, those who undergo previous colorectal resection, those with history of colorectal cancer, inflammatory bowel disease, familial polyposis, PJS, and other polyposis syndrome, and those who are unsafe for polypectomy, including those with uncorrected bleeding tendency, were also excluded. Of course, we also exclude those with poor bowel preparation. The main endpoint is the proximal adenoma miss rate as well as the proximal adenoma detection rate. All of our potential patients after exclusion was undergo randomization. We randomized our patient into two groups. Group 1, we first do an AI-assisted colonoscopy during the first withdrawal, and then we reinsert to the second, and then we undergo the second withdrawal under conventional colonoscopy. For the second group, for the first withdrawal, we do the conventional colonoscopy during the first withdrawal, and then we reinsert to second, and then we do the second withdrawal under the same conventional colonoscopy. As you can see in the diagram, you can see that we first insert the colonoscopy up to cecum, and then we perform the first withdrawal up to the splenic fracture. And this is known as the first withdrawal. Any polyp or adenoma detected during this first withdrawal, we call that detection rate. And then we reinsert the colonoscopy to the cecum, and then we perform the second withdrawal. Any lesion, any polyp or any adenoma we detected during this second withdrawal, that means the tandem colonoscopy is defined as a missed lesion. A proximal polyp or adenoma detection rate is actually defined as the proportion of patients with missed adenoma or polyp detected during the second examination, that is the second withdrawal with white light only. That is the conventional colonoscopy. For the proximal polyp and adenoma detection rates were defined as the proportion of patients with at least one adenoma or polyp detected during the first examination by the assigned method. All procedures were performed by the same high-definition endoscopic system, that is the Fujifilm 7000 system, under white light by experienced colonoscopy. For the computer-aided detection system, actually is a in-house deep learning AI model specific built for the detection of colorectal polyp during the real-time colonoscopy. As you can see in this video, a bounding box will indicate the presence of a polyp during the real-time colonoscopy. Actually, this particular AI model has been validated in our pilot study, which published 2 years ago. And this AI system in our pilot series actually able to detect at least one missed adenoma in 26.9% of patients and increase the total number of adenoma detected by at least 23.6%. There are 3 centers actually involved in this multi-center controlled trial. First is Queen Mary Hospital in Hong Kong. Second is the Hainan Medical University Hospital in Vietnam. And the third is the Tan Tock Seng Hospital in Singapore. A total of 417 patients were enrolled in our study. After exclusion of the reason mentioned in this figure, that a total of 220 patients were eligible into randomization. 111 were allocated to AI group and 112 patients were allocated to conventional group. After further exclusion due to pathological loss or poor bowel preparation, both groups were able to recruit 108 patients for final analysis. As you can see in this table, you can see the baseline characteristics were fairly similar between the computer-assisted detection group versus the conventional colonoscopy group in terms of the age, sex, indication, bowel preparation, as well as the insertion time and the withdrawal time. And we found that the polyp detection rate and adenoma detection rate were significantly higher in the computer-assisted detection group. And the mean number of adenoma per patient as well as the mean number of polyp per patient were also higher in the computer-assisted detection group versus the conventional colonoscopy. However, for the advanced adenoma and the severe polyp, there is no significant difference between two groups, either the detection rates or the mean number of them. Unfortunately, during the second withdrawal, that means the tandem colonoscopy, we look at the miss rate, there are no significant difference between two groups. We further undergo subgroup analysis, and we found that there is a higher detection rate with computer-assisted detection model in endoscopies with lower adenoma detection rates. For those who with withdrawal time less than 5 minutes, the bowel preparation less than 5 in the proximal colon, as well as screening colonoscopy as shown in this table. So in conclusion, our multicenter randomized control trial confirmed the enhanced proximal polyp and adenoma detection by deep learning CADe system, but there is no reduction in proximal lesion risk rates. Subgroup analysis showed that endoscopies with lower ADL, shorter withdrawal time, relatively poor bowel preparation, and screening colonoscopy may benefit more by the use of the CADe system.